We're going to go ahead with our third panel. Very excited about it. And I'm pleased to introduce Alyssa Smith, a partner here in our healthcare group, who will introduce her panelists. And the panel is Delivering Value in Behavioral Health Through the Use of Data and Technology.
Hi, good morning, everyone. As Shira said, I'm Alyssa Smith. I'm a partner and co-chair of our Health Transactions and Regulations Practice Group at Dorsey. I'm really excited to be moderating this panel. It's a very interesting topic in terms of how do you deliver behavioral health or mental health care in a digital way or using data and analytics. And we have a great group here to talk about that. So I'm just going to talk to you a little bit about their backgrounds, starting with Dr. Monica Roots. Dr. Roots is a child, adolescent, and adult psychiatrist and is the chief medical officer of Sembello Health, a virtual mental health company. She's also a clinical adjunct assistant professor at the University of Wisconsin-Madison. Previously, Dr. Roots was the chief medical officer of Cog Cubed, a behavioral health analytic company. Teladoc acquired the company in 2016, and most recently, she was the vice president of health services and behavioral health for Teladoc Health. Next is Jacqueline Wainwright. Jacqueline is an international behavioral health expert and the CEO of Air Care Health, a next-generation behavioral health care company. She's challenging the status quo over how our system is failing to provide effective treatment for mental health disorders. Air Care's unique approach combines both the heart of clinical care management and the science of AI and machine learning to transform the health of large populations. Jacqueline's work has the potential to help eliminate the burden of chronic diseases and revolutionize the health and happiness of individuals, families, and the entire community. And finally, Ross Manueli, my partner in Dorsey's Healthcare Transactions and Regulations practice, and also the co-chair of Dorsey's Healthcare Industry Group. Ross is committed to translating a complex healthcare regulatory environment into practical and concrete advice for his clients. Ross works in the healthcare provider, payer, and drug and medical device segments of the healthcare industry, including companies and providers who are using technology and data in healthcare. I wanted to briefly start by talking about mental illness, and I'm going to talk about how prevalent it is and some of the implications. There are some materials in our handouts with a lot of statistics. I'm just going to cover a few of them to sort of set the stage about what the problem is that these two leaders are here to talk about that they're trying to solve. So as we know intuitively, just from our own personal experience and conversations, mental health and mental illness is a big problem. According to a recent Gallup poll, 8 in 10 Americans experience significant stress. That's a huge number. Also, 40% of Americans experience some form of mental illness. That translates to about 60 million people are experiencing some form of mental illness. So to me, those numbers are staggering, and we clearly have a problem. There's been a lot of research done on the impact of mental illness, and I'm sure our panelists can speak a little bit to that, but I'm just gonna point out a couple of some of the major impacts or implications. First, there are implications on physical health. This is something that wasn't intuitive to me, but I've learned that people with depression, for example, have a 40% higher risk of developing cardiovascular and metabolic disease than the general population. Also, a Robert Wood Johnson study analyzed the impact that mental illness has on health outcomes of individuals who have chronic medical conditions like cancer, heart disease, diabetes, and found that mental illness, such as depression, actually decreases the likelihood of successful management of these chronic conditions. The odds of noncompliance with treatment are 3 times greater for depressed patients, for example, that leads to an exacerbation of medical conditions, a doubling or tripling of the cost of healthcare, and a decrease in quality of life. In fact, having a mental illness is associated with a double to quadruple increased risk of premature death due to natural causes like cardiovascular disease, just because mental illness contributes to people not following through with their health care. Mental illness and substance use disorders are involved in 1 out of every 8 emergency department visits, and we all know emergency department care is the most expensive care that can be delivered. For caregivers, there are at least 8.4 million people in the US providing care, unpaid care to loved ones with mental illness. 20% of homeless individuals suffer from mental illness. Large numbers of individuals in our criminal justice system have been diagnosed with mental illness. And then there are studies that estimate the total lost earnings overall into the US economy that can be contributed or attributed to mental illness, and it's estimated to cause $193.2 billion in lost earnings each year, with depression being, for example, a leading cause of disability that can contribute to those lost earnings. And finally, suicide is something that is a second leading cause of death among people aged 10 to 34. So with the impact of mental illness being so tremendous, the question's always asked, well, what is being done about it, or what isn't being done about it, and why? Unlike physical health issues, mental illness, we've heard today from previous panels, there's a stigma in our society around talking about it, around getting treatment for it. And so that is part of why people aren't seeking treatment. Also, there could be other factors that contribute to it, such as access to care. There's been studies about the shortage of providers in the country, and a statistic I found was that 60% of US counties do not have a single practicing psychiatrist. So today, with all of that background, we have the pleasure of talking to leaders from 2 companies that are doing something about the problem. They're using digital tools and data and a whole lot of visionary thinking and compassion to provide some solutions. And we're going to talk with Monica and Jacqueline about some of those solutions. And since this is a legal conference, Ross is here to talk to us about some of the legal and regulatory challenges that face, especially the use of technology in behavioral health. So with that, I'd like to turn it over to our panelists and start with a question for Jacqueline. Can you just tell us a little bit about your company and what Air Care Health is doing to solve this problem?
Yeah, so thanks for having me here today. It's great to be here and be talking about such an important topic. So Air Care Health, we like to call ourselves a 20-year startup. We've been around for a long time, delivering individual care and care to families that struggle with substance use disorder, depression, anxiety, bipolar, schizophrenia, and all of the other anxiety and stress disorders that fall in between. And so we've had a lot of experience. We've seen a lot of people suffering in silence. And I think that that can really impact you when you know people are out in the world not getting the help that they need, feeling very alone and isolated, and that there is help available to them, or there are resources that can really help them live a life in which they're thriving and contributing and happy. And so in our early years, we were waiting for people to call and ask for help. And essentially, people don't call and ask for help until things are really bad. And so when we look at the number of people in the United States or in the world that need access or need some type of behavioral health intervention or mental health care, about 70% of those individuals will never ask for help. They will never receive treatment of any kind. And so for us, that was an unacceptable sort of statistic, that there are tools available, and those tools, like remission is possible. It's a very treatable, in most instances, disease or disorder. And so that gap gave us an opportunity to say, what could we do with data or technology to find the people that need help, maybe even before they understand or realize that what they're suffering from is depression or anxiety, and therefore get the solution to them before they come crashing into the system. And so we started talking to some technology partners, and Microsoft stepped up as a great partner that was willing to sort of put some resources into this idea of data being some type of currency or ability to leverage data in a way that would allow us to find those people and reach out to them and offer them help sooner. And so we have been working with large employers and health plans to find people and offer clinical support to those individuals proactively, which is sort of a new thing. And people always look at me and say, well, how do you call people? Or, what do they think when you call them and you say, we have your data? And we don't call them and say that. But I think, what we're realizing is people are hungry for human connection. They're really deprived of attention and compassion and empathy. And so we've had the opportunity to really combine two very different things, data and technology, and then this power of human connection and empathy and the ability to heal just through a relationship and that constant sort of connectiveness. And so that's what we're doing. We're trying to change the world by healing people, leveraging technology to put people together so that they can get what they need to thrive.
So you said you work with employer-sponsored health plans. How do you reach out to individuals, or how do you find the individuals?
So we find individuals. So we leverage claims data, both pharmaceutical, medical, eligibility files. We also get HR data from employers, which is a big piece of the puzzle, especially for people who don't have coverage under the health plan. And we've got about 35 different models, machine learning models, where we're pulling data in and we're looking for patterns or looking for absence of data. And I'll give you an example of a unique way that we're finding individuals. So it's not just about maybe the data that we find when you visit the hospital or you go to see a doctor or provider, but it's more about the story and the interconnection of the data and how the household may appear. And so we're working with an employer, and we noticed that a mother, she had 2 dependents on the plan, was driving 45 miles to take her son to see an asthma specialist. He had asthma, and it required her to really 2 or 3 times a month go and drive that distance, take her son out of school, and get him, seen for asthma. And, what we know about human beings and the stress of raising children, and let alone having to take those children out of school to go and see a healthcare provider, we knew that at some point would start to take a toll on that mother. And so in an effort to connect with the mother to provide her with the support she needed, we reached out to her and said, we couldn't help, we're a benefit provided by the employer, and we couldn't help but notice that you are seeing a asthma provider or specialist 45 miles away. That's a long way to drive. What if we could get you in to see a provider that we know is, would accept your son as a patient and lives only 10 miles away? Would that be helpful? And the mother broke down and started crying on the phone because nobody had ever called her to offer her a solution to a problem that was healthcare related, that was just life related in a lot of ways. It wasn't it was something she was expected to do for her child and would continue to do. But the toll that takes on a mom, let alone on a family system, are not things that we look at often as healthcare providers. And so the conversations are more focused around how can we help to make life easier for you, or what could we solve, what kind of problem could we solve that would really open up the conversation for us to help you in other ways. So it's small, subtle, sort of pieces of information that lead us to believe that an individual is really struggling in what we call, life kind of ways, like life, the daily struggle, that we don't have symptoms to treat other than, life is hard and I'm struggling. But without a diagnosis, there's not a clinical pathway that will give you a solution or a pill. And so we're trying to solve for those other things, the daily life things that keep people away from doing what they love and contributing to their job and being a functioning member of society.
That's wonderful. Thank you for sharing. Dr. Roots, can you tell us about what Sembello is doing to solve some of these major problems that we've heard about?
Yeah, so Sembello is a virtual care company that's really focused on meeting a person where they're at. And what does that mean? There are a lot of people, as we talked about, who fear stigma, they fear having a label, they fear even talking to a person. And so Sembello was created based on an app that was called Pacifica. That app now has over 3 million users. They're accessed through the App Store, and that number alone, to me, speaks volumes. There are people out there who really want access to a tool as a sense of support. The way they want to seek care is the way they want to seek care. They want to be listened in that way. And they also want to feel that sense of agency, that sense that they are seeking the kind of care that they want at that time, and they have the autonomy to kind of choose that. So Sembello in its app contains many different things. That includes CBT tools, so it's really focused on evidence-based clinical practice, CBT in short, consumable bits of information through audio, video, text, and activities that a person can do on their own, in their own time. In addition to that, we have assessments that actually measure how are you doing over time, and that kind of reflection, feedback back to the patient or the user seems to be really valuable, as well as we offer mindfulness and meditation. Not everybody wants CBT. And we also have communities. So our communities are actually one of the biggest attractive pieces that we find our users really like, which is basically their peers in a chat room, really supporting them day in, day out through kind of, as we talked about, the stress or battle of everyday life. Sembello is really focused on now towards building a much bigger virtual care system. So what do I mean by that? That now building on the app towards adding coaching, therapy, psychiatry, and full PCP integration. So really closing that feedback loop to the PCPs. We really think that with that coordination of care, we really have the opportunity of, 1, meeting a person where they're at, 2, early identification and prevention, 3, really good quality of care, and once again, focus on closing back that feedback system and potentially even connecting a person to a PCP so they really can connect that whole idea of treating the mind, head, and body together.
So it sounds like you reach individuals by them subscribing to the app. Then how do you envision taking it the next step, working with partners such as providers?
Right, so right now it really has been a direct-to-consumer, which, coming from as a child psychiatrist, that was amazing to see. As we go forward, though, our customers are actually very large universities offering this to their students, employees, self-insured employers, large payers, as well as continuing to look at this direct-to-consumer. But we are also really focused on really the payer-provider relationship because, as we know, especially in mental health, behavioral health, our PCPs are kind of suffering through it on their own. They've got 10 minutes to basically get an evaluation done, see how you're doing, how's the progress, let's do a medication, let's document, move on. So, and when they do potentially a referral to a behavioral health specialist, they're waiting 6 months for a psychiatrist, 30 days for a therapist. Well, probably that stressor is either ballooned into something much larger or potentially even gone away and that person no longer seeks treatment because they didn't get the care they needed at that time. So we really think that that relationship of the PCP being able to coordinate with us, get their patients in to see them, actually getting data back from us on how their patients are doing, because as we know, that system is pretty broken. And not just that, but really focusing on getting the person to the right care at the right time. So though our PCP partners might say, we need a medication evaluation. We're really focused on actually doing an upfront evaluation, getting to them to the most appropriate care. Maybe they don't have a diagnosis and the app and maybe coaching would be great for them. Maybe they just need some therapy. Maybe they need all levels of care. So we're really focused on getting the person to the right care at the right time.
I'd like to hear from both of you. This conference is about value and how value is delivered through digital technologies and data. What do you see as the main value proposition for your company's use of technologies and data in this way?
I can take that first. So we are really focused on the idea that a better experience is better medicine. So being able to be there for a person when they need you, but also making it very approachable, really giving the information in various different ways because everybody learns differently or wants support in a different way. We think that that experience with really simple to use but very immersive tools, such as our digital health app, is a really good way of getting the medicine to them in a really consumable way. But not just that, if they need additional care, really building on that sort of experience, but also not necessarily forcing them into it. So if they're ready to seek that care, we're really going to try to help you get that care. But if you're not ready for it, we'll continue to support you until you feel ready.
Yeah, and I think that's absolutely true. We don't focus enough on the patient experience. In fact, oftentimes you'll hear providers and digital companies all talking about the way that their clinicians or the system is experiencing the new device or the technology, but we don't often look at the patient in the equation or enough. We don't look at the patient's experience enough. And so for us, I think value is delivered in a lot of ways, and especially when we're partnering with different entities. So to an organization, it has to be that member experience, like for a Best Buy or 3M or a Microsoft, you need to make sure that you're taking care of their people first, right? And then second, it needs to be for a fair price, right? So you cannot charge a PM service across the population when you're engaging 10% of the population. We like to say that we engage 100% of the people that you pay us to treat, meaning if we're not effectively providing care that is measurable and that there's an outcome that we can show you, then we shouldn't get paid for that time. So it's all about, for us, trying to deliver on the monetary side of things as well as the member experience and then the health outcome, because we need all three for things to work effectively long term.
So are the partners such as the employer health plans you're working with, are they looking for a reduction in their healthcare costs? Are they looking for improved happiness and well-being of their workforce? Or what do you see resonates the most with those partners in terms of what they want to get out of it?
Yeah, it's a great question. I think if only I knew the answer. I think every employer is a little bit different. I think cost, especially in today's age where the healthcare costs keep rising, and that's a trend that people would like to see change. Cost is definitely a factor, but I think the nice thing about working with large organizations that have a robust sort of benefits department or even human resource department that is interested in investing in the human capital that they have available to their organization, the member experience wins out. That employee, valuing your employee and wanting them to be present when they're at work and have work-life balance. That's definitely a reality for a lot of these companies. It is not, I've been pleasantly surprised to find out that a lot of these large Fortune 100, Fortune 500 companies, they understand the equation and the relationship between, a productive employee and that employee having their well-being needs and their physical health needs being met, and that those two things go together. And so I think we all know that, we cannot have people working around the clock 24/7 and also, being able to sustain that long term if they're not getting, A, that's not healthy, and B, there's no way they can get any of their other needs met. So it's this sort of work-life balance and putting that first.
I would add on to that, and I think both of our companies are doing this. Employers have a very big issue of access, especially in behavioral health. So there are only 8,000 child psychiatrists in the nation. I mean, I could work around the clock and still not meet the need. There's only about 16,000, maybe plus, general psychiatrists, right? So when I was in school, I was taught, by the time you graduate, you're probably going to be running teams, probably not seeing patients, just for the very reason that you don't have time to be seeing everybody that needs to be seen. But in addition, the access problem is coverage. So because there's a limited supply, many people are out of network, they don't take insurance, their rates are extremely high. So from an employer standpoint, I think part of the value is that we're providing access in a timely way, but also using their benefit and being within network so it's affordable for their employees to actually use it. The additional piece about that, I think, is a challenge in behavioral health is that one of the biggest critiques is that it's always been a very gray zone discipline. Many of us have not actually measured, using evidence-based tools, how bad is your depression and anxiety, and are you actually getting better? So only about 12% of clinicians actually measure in the behavioral health field these outcome measures. So I think that we're really focused on, both of our companies, not just giving a great experience, giving access, but let's actually measure. Are you getting better? Are you getting worse? And being able to give that information back to the employer, I think, is really important. In addition to that, I think we're also focusing on what are your comorbidities. So actually looking at, do you also have COPD? Do you also have heart disease and diabetes? What is happening with your medical spend there? And giving that information back to the employer, I think, is a very powerful tool that, using data to show, yeah, your mental health is getting better, your presenteeism is actually getting better, your absenteeism is going down, but also your medical spend is potentially going down. I think that that's the potential value that we're adding.
And I think it's, we were laughing earlier about the fact that companies don't have that data to prove that their model's effective. It's astonishing to think that you're providing a service to a large population and you don't have the data to show that it's working. And we live in a day and age where quantum computing and storage, none of those things are obstacles anymore. We really have no excuse to be providing digital health services and not have a very clear trail in terms of what are our outcomes, how well are we achieving the benchmarks that we've set, and what are we delivering on in terms of value to the organization and to the patient.
So Ross, I want to bring you into the conversation. You advise a lot of digital health and telehealth companies, from providers to developers to vendors. And in many cases, the law has not caught up to the technology. Mm-hmm. So that's a constant challenge. Can you describe some of the main legal issues? I think we've heard this morning about data privacy and security and some litigation challenges. But could you go through some of the regulatory challenges and legal issues that face digital health companies, especially in the behavioral health space?
Yeah, so in the last session it was alluded to, I think almost every one of the main challenges comes out of our federal system and the fact that the delivery of healthcare is regulated at the state level, which means you have 50 different regulators. And I don't know of any company who actually provides any type of clinician visit remotely that wouldn't love to live with just one federal law, regardless of what it said, or what it required them to do. And so in the last session, the focus was on licensure, which is an issue, but I want to expand on that because it goes well beyond that. So even structuring how you deliver services within a state will depend upon state law. So you would create a professional corporation in wherever your main site is or where your main clinicians are. And when you want to provide service in other states, many states allow that foreign PC to do business in their state. Others don't. So you have to create a domestic PC in a particular state to even practice in that state. Furthermore, then you have to look at that domestic PC and say who can be the shareholder. And does it have to be someone who is licensed in that state, or can it be someone who is licensed in a foreign jurisdiction vis-a-vis that state? And then there are some states, New York in particular, but that whatever practices, whatever professions you are practicing in that state, you have to have a licensee of that profession be an owner of the domestic PC. So all of that stuff adds complexity before that's just structuring your corporation for practicing medicine in the state. And then you move on to before you can get to a remote visit with a patient. Many states, not all states, but many states have particular telehealth regulation that deals with a number of different things. But one of the big things is the informed consent. What you have to tell the patient before you can deliver a telehealth service. And it varies from state to state. Some states require that you tell the patient the name, the license number, the location, or the credentials, including board or specialty society certifications of the clinician before you can start that visit. Others require that you tell the patient about the risks of performing the visit via telehealth. What to do if there's a technology disruption, particularly around telepsychiatry, right? If I can't get to you, where can you go for help? What are the risks to confidentiality? What third-party websites do you use? All of these things are not in any one particular state laws. I'm just outlining things that are in various state laws. And if you are, Greg used the term diffusion, which is a great term. If you are diffusing the service across various states, these things accrete, right? So you have to give the patient all of this information to comply with all of these various state laws before you can even reach the patient. There is a unique element to this around behavioral health because typically, if you want to provide behavioral health, you are going to have many different types of clinicians with different types of licenses, right? So you might have MDs, you might have social workers, you might have therapists, psychologists, psychiatrists. They all operate under different state rules and have different state boards that regulate them. So once you have multiple clinicians in multiple states, now you've got a matrix of rules you have to follow. So that gives you an idea, I think, of probably what is the biggest risk. You add on top of that typically in a behavioral health setting, you want to prescribe medications. That's part of it, right? And so that's a different layer of complexity because particularly with advanced practice nurses, depending upon the state, they might have to go get a certain certification or a different registration in order to prescribe to patients in that state. And you can't miss things like that because what's at risk in any of those issues is not necessarily the corporation's bottom line, it's the clinician's licensure and their livelihood. And it becomes, in a corollary fashion, very important to the bottom line of the company because one of the easiest ways, I guess I should say, for clinicians not to want to work for you is if you're putting their licensure at risk, right? There's also some of these things come out of federal law. There's the Ryan-Haight Act, which says that you can't prescribe controlled substances for someone if you are solely treating them remotely. And there are some exceptions to that, but those exceptions are typically if the patient is in a hospital or if they're being cared by a physician in person. But if the interaction is solely remote, federal law says that you can't prescribe controlled substances for those patients. The other thing, one last thing that I'll mention is the corporate practice of medicine laws, which are still laws in over half the states, which say that a business can't practice medicine. Typically, these services are provided with some business corporation that has invested in the technology and the infrastructure that's involved in this. And oftentimes they will play a role in managing the professional corporation. You really have to be careful in many states, particularly New York is a great example, probably the strictest state. We're kind of beating up on New York because of this code thing that we all have to do. Like they just regulate a lot in New York, right? But they are also one of the strictest corporate practice of medicine states. And so the business corporation can do all the administrative and management functions, but really has to draw a line at getting into clinical decision making and tell the clinicians what to do. And a contract can help and can say that, the clinicians do have sole responsibility for X and the business corporation can do Y. But there has never been a corporate practice of medicine issue that has arisen because of a contract. They arise because what happens in operations is that the management company gets involved in the clinical activity. A big corporate practice of medicine enforcement action by the New York State Attorney General happened in the dental area. And what happened there was patients were having complaints about their crowns or their other dental care, and they would call the practice and complain about the clinical services being delivered. And the management company was the one that was dealing with those complaints, and trying to anyway. And what happened was that was very frustrating for numerous patients, and they just called the Attorney General and said, this is not right, and that's how they got a hold of it. So I would say that the companies that do this best, I would say there's two main factors. One is having an appreciation for the level of infrastructure and personnel you have to devote to dealing with however many states you're in, their state boards, and dealing with all these regs to protect the licenses of your clinicians. So just being ready for that, recognizing it, and devoting the right number of resources to it, it's kind of like a compliance thing, but you have to do it. The other thing is having teaming with clinicians that are involved on both the clinical side and the business side, so that they can advise the company where the appropriate lines are for what the management company does, who's looking after the business interests of the company absolutely correctly, and where the management company has to stop and let the clinicians do their work.
So Ross, thank you for talking about some of those legal challenges and the ways that companies do this best, how they overcome them or at least address them proactively. Jacqueline and Monica, I'm interested in what some of the main challenges are that you face, whether they be legal or if they're more operational or dealing directly with patients.
So Ross outlined many of the challenges
Nobody's
that
gonna
we
wanna go into behavioral
experience on a daily basis. But I would say one additional thing that's top of mind for me is that there's an aging population. Medicare has restrictions on the originating site of where a person can access care. Medicare Advantage is starting to make moves in the opposite direction, but these individuals who are retiring and have Medicare are actually extremely digitally savvy, and they actually want to access care the way they want to. And I think that there's going to be a much bigger population that wants to seek virtual care, including for behavioral health. But beyond that, you think about the assisted living facilities, the nursing facilities. Every time there's an emergency or a doctor's appointment, it is a monumental effort to get a person to an office, a hospital, a clinic, etc. So it is a very logical space for virtual behavioral health care to go. And I see that, the Medicare originating site is another barrier that I think will be something that will need to be addressed. But I also think that, there are interstate compacts that are trying to help with the licensure issue to be able to get licenses a little bit faster. But I think that, the continued focus on controlling the licenses in the states, especially if we think about California, and each individual county really controls the Medicaid care that they get within their county. The regulation down to the county level really makes it a challenge for a virtual care company to be able to deliver adequate care.
Yeah, well said. I think that's, just the beginning in terms of the issues that or the obstacles that we face. And I like to, for us, one of the largest hurdles was going from just a behavioral health company that is providing care to individuals and families to now I'm a digital health company and now I'm a tech company in a lot of ways. And what does that mean? And we need an information security protocols and programs and data, how do we use the data? Where is it stored? How do we access it? Who's accessing it? for what we started as a very small organization delivering care to families and individuals, that was sort of an overwhelming obstacle to have to overcome, but yet an extremely important and necessary step. I think, there are healthcare companies that unfortunately learn that lesson the hard way as they make the transition into the digital space. But it comes down to, if we can't be trusted to adequately protect, store, use, and have data in our hands, and we don't protect that data and sort of show others that is an important step, then I think we will lose the privilege of using data. And it's become such an important part of, I think, healthcare delivery and the experience that hopefully it's something that other healthcare companies that are looking to make sort of the digital leap take seriously. And same with we talked earlier about the companies that are the Silicon Valley, the tech companies that are trying to come into the behavioral health space, but really don't understand healthcare and all of the complex privacy laws that come with it, just like the digital and technology laws that they're used to understanding and overseeing. So I think that's been a big challenge for us as an organization, to make that pivot from, okay, we're a healthcare company and we understand all of the legal, or most of the legal requirements with Dorsey's help, to be a healthcare company that follows the rules and keeps patient confidentiality and secures records and things like that, to being a digital healthcare company that understands how to protect data and has safeguards in place to do so.
We heard this morning from Best Buy and others about, and Mayo Clinic, about how important that data privacy and confidentiality and security is. Sort of, they talked about they're presented with these tools or ideas from startups, and that's one of the main issues. Is that something that you hear from partners as you're in your initial discussions with them and on an ongoing basis?
Yeah, I think that for us, our CTO and CIO are on a daily basis working specifically on this. We really focus on really having our data warehouse and our data really kind of in a highly secured way, but beyond that, our electronic health record and our selection really is focused on how can we make sure that our data is meeting all the regulations so that we can exchange data a little bit easier, because of course whatever partner you're going to work with wants that same certification or high level of security. So for us, it's a battle of making sure that we're meeting all those requirements internally, but also making sure that we have the trust of the external partner.
Yeah, and sometimes that means you don't get to work with people because they just simply cannot meet the standards. And I think that that's a huge risk if you're taking all of the steps to safeguard. You have a CIO, you have a CTO, you have information security protocols, you put your staff through that training regularly and address issues regularly. If you don't have that sort of feedback loop and you're not doing that on a daily, weekly, monthly basis and keeping records of how you're auditing that type of sort of system, then you're not meeting standards. You're not even meeting the basics. And so I think that becomes a lot to take on. And it also means that you need to ensure that your vendors also are doing the same if they have any access to or insight into that data. And a lot of times they look at you like, you want me to sign what? Like you want me to show you what protocols are in place? And I think at the end of the day, if it's a worthwhile partnership, they'll jump through the hoops or do the things that are necessary, but it's not always easy.
So we wanted to leave plenty of time for questions. I'm guessing there's a lot. I have a lot of questions just that have come up from this conversation up here. So I want to open it up to the audience to ask questions. And I'm going to just pause after you do because I need to repeat it for the recording. So please. Yes.
You've discussed the impact of the different state regulations, and this isn't just a factor for behavioral health, it's a factor across all the entrants in digital health. what's happening at the legislative level or the lobbyist level to, shall we say, level the playing field across the different states? And to what extent do we need to be concerned with groups such as the AMA preventing that from happening?
The question was acknowledging that there is a patchwork of state laws and they're all quite different, and what initiatives are taking place right now at the federal or state level to help to maybe standardize or synthesize these laws to make it easier. As Ross said, many of our clients would prefer to just have one law to comply with. They don't even care what it is, just as long as they can understand it. To what extent does the AMA maybe act as a barrier to some of that progress?
Well, I'll take a shot at it. I think I'm sure there are lots of efforts, and I think that the efforts are can be successful and make some progress around the margins. For instance, Congress basically recently told the DEA that they had to mandate it, that they come out with a telemedicine DEA registration. The rules are not out yet, but they, hopefully will be by the end of the year. It was something that was authorized for the DEA to do in legislation years and years ago, and they just never did. So there are some things like that. There may be some things, again, around the margin at the state level, but I agree with Greg from the last session. I don't think it's going to change fundamentally. I don't think there is any realistic possibility that in the near term, by any stretch, states are going to give up their authority to self-regulate professions within that state in any meaningful way. So, I don't necessarily think it's the AMA. I think it's our federal system, and I just don't see it changing.
Yeah, to add to that, so there have been really significant lobbying efforts just for telehealth in general in the last 6 to 8 years, and it's been pretty aggressive. So I would say that in that amount of time, we've had a lot of successes. So we've now been able in many states to be reimbursed as a service that's akin to a brick and mortar service. We've removed the GT modifier, so we now can actually build the same codes. So from a billing process, that's much better. We're now actually starting to define what is reimbursed. Is it synchronous, asynchronous, store and forward? So we are making significant strides, but I think, back 10 years ago, you would say telehealth and people said, I'm sorry, what? What are you talking about? So you can see a doctor and that's okay. How dangerous is that? So there's been significant movement, I think, in the last decade. Will we make the same amount of strides in the next decade? That's really hard to say because once again, I think that now we're kind of encroaching on the bigger strongholds on how can I continue to monitor what's happening in my state. But given the amount of momentum we've had in the last even 5 years, I think that there is definitely potential.
I do think the employers are playing a large role in helping to inform and address that policy, especially those employers that have, like the Microsofts, the Googles, the Amazons that have multiple employees, large amounts of them in several states, and essentially suffer because of that, the laws that restrict us from treating those patients effectively, or even understanding what it looks like to care for a population when they reside in 50 states or globally, especially. And so I think, they have a lot of the, power or money to try and lobby for those, at least in the right direction for the states and the law and regulation to be open to that sort of change.
Yeah, I think I took the question more to be about making uniform state laws around some of the things I was mentioning, but to pick up on Monica's point around the reimbursement, that has changed a lot, despite the restrictions in the Medicare program in particular about where, in what areas of the country, rural areas or non-MSAs, the telehealth benefit is available. And then generally patients can't be at home and access it than for ESRD. That is changing. And every single year, there seems to be more codes that CMS reimburses around remote activity. Every legislation around healthcare, Congress authorizes more telehealth benefits. I think at some point that has to break down because, as Monica rightly alluded to, it doesn't make sense for Congress to think that their Medicare beneficiaries in Manhattan get less benefit from a telehealth visit than somebody in a rural area. That's going to seem more and more anachronistic. The only thing that I can think of that would stop that from happening is fraud and abuse. I mean, I don't think it's appreciated as much as it should be that one of the largest fraud settlements this year was around a telehealth business that through a call center just generated fake prescription and DME orders and they were cooperating with physicians who wrote those orders. And they prosecuted about 23 companies and individuals, and it was a $1.2 billion recovery for the government. That's the only thing that I think could realistically really slow down Congress deciding to opening up that benefit.
Yes.
My question is more on the software development side. I'm just curious, how do you humanize machine learning models? So, as developers, sometimes developers lose context about, when they get so involved in the machine learning model, because basically machine learning models are just a set of equations, logistic regression, and just optimizing those. But how do you truly represent user needs through these models? Like how is it about taking the engineers on the field and finding these parameters so that they understand this better? Because sometimes, like you said, that companies come in, but they don't really understand that context. So how do we do that as developers? Are there any best practices that you follow at your startup or something like that?
Okay, the question was for software developers and the use of machine learning, how do you humanize machine learning models? Do you bring the developers out onto the field to better understand how healthcare is delivered, or how do you provide that context for machine learning?
Yeah, we were talking about this earlier, and I think for us, there are some things that machine learning and AI will not do and may not do ever. And we believe that's, to deliver empathy, to be able to connect with human beings, that's why we don't replace clinicians with AI. Instead, we try and remove all of their obstacles to being and spending their time with the patient. And so we leverage AI and machine learning models to know who needs what type of intervention at what time and how they need it. And then we use the human being to deliver that intervention. And they're receiving data that may inform how they deliver that intervention, or also may inform as they're speaking with somebody more or better information about how that person is receiving that message. But to remove the clinician from the interaction, I don't believe will be as successful as having the human being be the messenger.
Yeah, so seconding that, I think artificial intelligence and machine learning is something that can definitely bolster the experience, but not replace the experience. I think that that's really the mindset that might be the most valuable. And when we talk about the experience, it's not just the patient clinician, it's across discipline, right? So it's about marketing, it's about sales, it's about operations, it's about the clinician, it's about the patient experience. So getting all of that input to really enhance that experience, gather tools, machine learning to really optimize that relationship, I think that would probably be the best practice that I would foresee as really moving the needle.
Yeah, there are plenty of problems to solve from an administrative or operations standpoint that we could reduce time spent or efficiency, and it'd be a big win, I think, for healthcare providers and patients alike.
Yes, sir.
And what I heard you both say really is the optimal pathway is eventually getting somebody to a therapist, and you're looking to provide tools and programs that will support them until they're at that point of readiness. There's also a huge stigma around mental health. So again, I'm on the group employer space, but that readiness or getting people willing to go out and see somebody again, that's a huge challenge in and of itself. What I'm seeing is once you got somebody there where they're actually ready to make that leap and see somebody, there's a huge chasm between their willingness and their ability to get in to see somebody, and on the provider side, finding the appropriate match or even getting somebody in. On the provider side, you've got multiple licenses, degrees, certifications. There's very little quality information out there. People generally don't make referrals or references. There's a provider shortage, so you've got these huge wait times. And with respect to prescribing, some can, some can't. So, my question for you guys is, what are you doing to, once somebody is actually ready to engage, help them engage with the right resource so that you're increasing the probability of a successful outcome?
Yeah.
Let me just quickly repeat the question. I'm going to synthesize it. The question is, how do you help patients once you've gotten to them to the point where they're ready to make the leap and to go see somebody for treatment? How do you bridge that gap and get them there? Because there's still a lot of barriers to getting them the access to care that they need.
So there's going to be a 3-part answer to your question. One of the things that we're really focused on Sembello is about making you a little bit better than you were yesterday. So our focus is not necessarily just on mental illness, it's about mental wellness. How can we keep you on the right side of care and prevent the downside into the mental illness? How do we do that? So once again, a lot of people in behavioral health don't measure actually how severe your symptoms are at baseline. And so they get a one-size-fits-all sort of treatment plan, which is go see your therapist, go do some CBT. Hopefully you feel better. You may not be functioning better, but you're feeling better. And we'll throw a medication in there just to make sure that you stay better. So that's kind of what's happening right now. What we're trying to solve for is, can we actually measure how severe your symptoms are? Can we engage you in the experience so you actually want to engage in some form of support, whatever that means? Can we guide you into the best treatment plan for you when you're ready? But not just that, how can we maintain that relationship for early intervention and prevention, basically? How can we keep you well so you don't need a therapist? That's essentially our goal when we think about it. So once again, it's the whole premise of keeping the people on the right side of care with the right treatment plan at the right time when they're ready to engage. And that engagement for us comes from the right experience.
I'll agree with all that as well. And I think for us, although we would like to think we're able to prevent every person or individual from ever having a mental health illness or having to have a higher level of care, I think that obviously it's not preventable yet. So for us, if people are in need of a higher level of care, which sometimes they are, we do look at first of all doing a basic need, baseline needs assessment, doing a clinical assessment to understand better what are their symptoms and what do they need in terms of a level of care. There are lots of tools. I'm not sure how many people use them out there in the world, but there are clinical tools to tell you ASAM for placement, and also lots of tools for a patient to use to understand how severe their symptoms are. But I think first and foremost, you need to be partnering with providers on the ground that can actually deliver you outcome-based data or help to measure progress, which, like you alluded to, the system's not necessarily set up to do today. And so we require of our partners on the ground or our provider partners for them to give us baseline data back. So if we're going to give a patient to a therapist or to an EMDR therapist or an inpatient treatment center or even an outpatient treatment center, there are certain data points that we're going to collect that we need in order to know whether that facility or provider is doing a good job at treating that patient. So I think having those types of sort of feedback loops are really important.
Unfortunately, we're out of time, but we'll be around afterwards for additional questions. Please join me in thanking our panelists. This was a wonderful panel. Thank you so much.